So welcome to the November CaTS webinar. Happy to introduce Dr. Terry Davis today with the Health Literacy Core of the CaTS Center. I'm going to hand it right over to Terry, but if you just joined us, please use the chat window to add anything you'd like her to cover or any questions you might have, and I'll relay those questions to Terry later in the presentation. So. That being said, I'll just step out, and thanks again for joining us. Terry?
Okay. So welcome, everybody. In the next hour or almost hour, I'm going to be talking about a little bit about the role of health literacy and improving health communication, our research, health outcomes. I think health literacy is an integral part of research, and I'm going to also be talking a little bit about measurement and informed consent. So the cartoon says, the doctor says, I better be health literate after giving the best years of my life to medical training, but the patient says, right, but can you explain any of it to me? And so that's kind of the crux of this. So what does CaTS need to know about health literacy? Well, the definition of health literacy, which came out in a IOM book, The Prescription to End Confusion in 2004, is the ability to obtain information, understand it, and use health information and services to make appropriate health decisions. So this is really key to improving health outcomes. But health research has shifted. In the very first years, we were assessing readability of everything. We were assessing patients' deficits. But now the onus is really on us, and it's important to realize that health literacy is affected not only by an individual's capabilities, but by our ability to make information accessible, clear, actionable. So is it easy to access information and services? Is it easy to understand it? Do we make it easy to act on it? The NIH has said we can't blame individuals for not understanding information that has not been made clear to them, that we haven't made clear to them. And that everybody, no matter how educated, is at risk for misunderstanding health information if the issue is emotionally charged and complex, and palliative care can be emotionally charged. So can cancer diagnosis, genomics is complex. The Department of Health National Health Literacy Action Plan calls for health information to be accurate, and most of the time it is accurate, but it is often not accessible, understandable, or actionable. Recently, these leaders in federal health agencies from CMS to DHHS, NIH, CDC, FDA have all commented on health literacy. And for informed consent and for anything else with healthcare, you must be able to get the information, understand it, to make an informed health decision. And so it's important, I think, as the director of HHS said, you have to meet people where they are, not necessarily where we are. And that research, according to Francis Collins, the NIH director, must provide information to the public that's clear and evidence-based so they can make sound and safe decisions about their health. So the FDA is very concerned about this. I'm helping them with a project right now about very specific language and what helps people and the public understand what they need to know in language from the FDA. So why is health literacy a problem? Well, about 90% of adults have difficulty using health information that's routinely available in our healthcare systems and in the media. Health professionals often fail to grasp the wide gap between what they want to communicate and what patients actually understand. The other thing, if you're talking about where health literacy projects can go, healthcare is changing. Health technology is changing. Every system wants you to use a portal now. Can people navigate the portals? Can they understand what's on the portal? What about research? Are they clear what they're signing up for? Are they clear what's being asked of them? Insurance is huge. You come off your parents' insurance if they have private insurance at age 26. If they don't have private insurance, you may be off at age 18. How does somebody like that begin to navigate insurance? Insurance for medicine if you're a teenager or a young adult with chronic illnesses. So all of this is rapidly changing, and all of these come with a lot of communication challenges, all the genomics research. Palliative care, people get mixed up with palliative care and hospice, and it's emotionally charged, so people have a hard time with this. It's difficult also for people to separate evidence-based information from misleading ads and gimmicks online and on TV. Recently came back from National Academy of Medicine meeting on health literacy in adolescents, and apparently adolescents get a lot of their information from YouTubes. And is it accurate? Is it evidence-based? It's trusted by them, but is it accurate and evidence-based? The problem here in Louisiana is exponential, because we rank 49th in literacy and 50th in overall health, and 1 in 3 Louisiana adults have low health literacy. Rates are double for low-income folks, minorities, the elderly, our most vulnerable populations. And Tanisha, I see that you're on the line in New Orleans. About 34% of adults have the lowest literacy level in a recent national study. So there's only been one national assessment of health literacy. It was really an assessment of literacy, but they asked 56 questions about health. And in this survey, it wasn't a telephone survey. They knocked on doors and just interviewed people that were at the house. And the health questions assessed functional, clinical, preventive, and navigational tasks. And so if you're on a below basic level, you could circle the date on a doctor's appointment slip. Our no-show rate up here is about 30%. And so can people organize their calendars? Can they read appointment slips? Do they know how to cancel an appointment? If you have basic health literacy, you can determine when it's okay to drink before a medical test based on short instructions. And intermediate, 53% of Americans were in the intermediate level, and they can determine what time to take prescription medicine based on the label. So if you look at these numbers, only about 12% of Americans have proficient literacy levels, and 36% would have trouble determining what time to take medicine based on the label. So in the basic or below level, almost over half of high school graduates are in basic or below. 60% of Medicaid recipients and 60% of people over 65. So this is who comes into a lot of our CaTS systems for healthcare. Low literacy is linked to all kinds of things, but if you have low literacy, you're less likely to understand and appropriately manage your chronic disease. If you have diabetes, there is so much stuff you need to know and do. To adhere to treatment plans, to take medicine appropriately. Increasingly in cancer, that people are given oral chemo. It is life-saving. It is no longer a terminal illness, but you have to be very adherent with your meds. If you have low literacy, you're less likely to ask questions. You have to have the words and the confidence to ask the questions. to accurately interpret labels and health messages, use preventive services. At our medical school, a lot of times women never get prenatal care, or they don't get mammograms, and so their breast cancer is very advanced when they come in. Understand discharge instructions, or understand consent for procedures and trial. They are more likely to have poor health and poor mental health, delayed diagnosis, more complications, more mortality, increased ED use, avoidable hospitalization, and avoidable readmissions. So here's a map of Louisiana by parish, and the red parishes, over 30%, have low literacy. They are in the lowest literacy category according to the first national literacy test. You notice that we do not have any purple parishes in Louisiana, where less than 15% of the adult
Terry,
population.
We've lost your audio, Terry.
You've lost my audio? My audio. Okay. Well, my audio, where is my... Can you come in? They've lost my audio.
Okay.
When did you lose it, David? I can't find the audio. Where's the button? Oh, you can't hear me.
No, Terry. Again, my fault, my bad. The guys on chat have confirmed that your audio is still good. It was just my machine, so you're still good.
Oh, okay. The attendees can hear me, but you couldn't?
That's right. But I figured out what happened. There was a power drop off in my office, but all's good now. Sorry about that.
Okay. Well, we're back, guys. So, if you think reading is a problem, numeracy is a huge problem. And a lot of healthcare involves numbers. And this was a research study done in Vanderbilt, and I love this. They gave people nutrition labels. And you drink this whole bottle of soda. How many grams of total carbohydrate does it contain? Well, it contains 67.5. How did you know that? Look at that label. How did you know that? So probably in your head, you multiplied the servings per container by the total carbs. And the answer was 67.5, but look, only about a third answered it correctly. So who are these people? Well, they were Vanderbilt primary care patients, and 73% had private insurance. That tells me they had a job. 2/3 had gone at least some college, and almost 80% read above a 9th grade level, but only 37% scored 9th grade or above on a standard math test. So Americans have a lot of problems with math. If you have diabetes, there's a lot of math involved, and Vanderbilt continued to do studies. And they found in these diabetic patients, 90% struggled to understand food labels. The FDA knows that. I invite any of y'all to do a research project trying to come up with a better nutrition label. A lot of dietitians at Pennington want to teach people. A lot of what they're doing in their weight loss programs is to teach people to read labels, but people don't know how to navigate them. They don't know what to do with that information. It's not helpful. It's not useful information. 2/3 of patients had poor estimation of portion sizes, but I've learned from Pennington and weight loss studies I've done with them that just about all of us are poor estimators of portion. We all think we're eating less than we are. About a fourth couldn't interpret a glucose meter, 40% couldn't calculate carbohydrate intake, and 30% couldn't dose their insulin correctly. I was doing a project in Arkansas this year, and the health coaches were in these rural clinics, and people just couldn't get their insulin straight. They just were chronically confused about insulin dose. So people's diabetes numeracy was associated with poor self-management, poor confidence in managing their care, and worse A1C. So look at this supper ticket. It's $23. The tip is 5 something, so that's about $29. And so I think this is maybe characteristic of many of us. Approximately half of U.S. adults are unable to calculate a tip. 1 in 5 college-educated adults don't know what's a higher risk, 1%, 5%, or 10%, or understood that 0.01 is the same as 1 in 100. And this is not just patients. Doctors have a hard time. In a recent study, only 1 in 21 OBs accurately estimated the probability that a child had Downs after a positive test. So math is, if you have a project or in your practice, patients have to be able to work with any kind of math. It's important to check to see that they're doing things correctly. So how do you know somebody has low literacy? They can say, I forgot my glasses, I want to check with my adult child. Incomplete intake forms, the names of drugs and diseases are long and complex. Frequently missed appointments, unable to give a coherent sequential history. We spend a lot of time teaching medical students how to take a history, but nobody teaches patients how to give a history. The lower your literacy, the more likely you are just to tell stories, not taking your medicine correctly, asking fewer questions, lack of follow-through with referrals. Also, if you speak a language other than English, it can add to the literacy problems. We need to do a better job of helping patients improve their health behavior. I tell medical students we do a pretty good job of teaching you how to diagnose and treat disease, but we don't do a very good job of teaching you how to work with patients to change their behavior, to manage their health, to manage their chronic disease, to manage their child's health, when to come in to the doctor. A lot of the health behavior information we give to patients, we're not really thinking through what we're asking them to do, what all is involved. We need to figure out what's unrealistic for a particular patient and partner with them to make a more realistic plan. We need to do a better job of communication and support. About 1 in 5 patients recall what the doctor tells them immediately after walking out of the doctor's office, and then within a week, they have forgotten over half of it. 20 to 30% don't fill initial prescriptions. Up to half don't take the prescriptions as recommended. Do they understand the benefit or the necessity to take as recommended? Do they have the capability? Can they take it at lunch? If it's 3 times a day, is that 3 into 12, 3 into 16, 3 into 24? You wake up the baby at middle of the night to give them medicine. You leave the doctor's office at 3 or 4. You get home at 4 or 5. It was 3 times a day or even twice a day. When do you start the first dose? Ironically, vets are a lot clearer with messages about medicine than physicians are. Patients are asked to perform increasingly complex self-care. You leave the hospital, somebody at home may be having to perform skilled nursing care. Who checked them out on inhalers, oxygen, all kinds of things? Patients often need help and support in changing behavior and sustaining that improvement, ongoing touch points. So here's some tips for all of us, whatever we're trying to communicate with patients. Slow down. Think about what it is they need to know and do. If you have diabetes, what is it that you need to know? What do you need to know this week? What do you need to do? A lot of times doctors waste a lot of time telling people all this nice to know, or all the things about diabetes, like all the bad things that can happen to you if you have diabetes. That's not helpful, particularly in how to manage it. So what do they need to know? How do they need to do what you want them to do? Avoid medical jargon, use plain language, use pictures, teaching tools, pamphlets, brown bags to help as teaching tools to help convey the message. Limit advice. The more we tell people, the more they forget it. Engage the patient, elicit buy-in and give and take. And write brief take-home information. Write them a bullet point slide with 2 or 3 points on it. Attend to their culture and their goals, what's important to them. And the only way to truly confirm understanding is to use teach back or show back, where you say, tell me how you're going to take this medicine. Show me how you're going to use this inhaler, etc. And it's important that all of us are positive and motivating, because it's the patient that has to do this. And the more we touch base with them, I think the more that helps them know that we care and we are helping support them and clearing up there have been a lot of studies of pharmacists calling patients after discharge from the hospital, and like 60% were having mistakes with their medicine. And that's one of the main reasons patients are readmitted to the hospital. They're not taking the medicine, or they didn't get it, or they couldn't afford it. So here's some strategies for limiting information. Tell me what's wrong. What's wrong with me? What's my diagnosis? What do I need to do? What's the treatment? What's the self-management plan? And why is this in my best interest? If you don't tell people the benefit, they don't know. If you take hypertension or diabetes medicine, you don't feel any better. A lot of people who start taking medicine for chronic disease have never taken medicine before except antibiotic, where you feel better within a day or two. If it's medicine, patients have taught me, break it down for me. What's this for? How many pills do I take at a time? How long do I take these pills? Forever? For 10 days? Why is it in my best interest to keep taking these pills when I feel better or don't feel worse? Or I may even feel worse. Why do I need to keep taking it? What to expect? What side effects? If I have a headache or upset stomach, is that temporary? Or if it's not, how do I address that? How much does this medicine cost? Will my insurance cover it? Are there other options if it costs a lot? Pictures can be good teaching tools. This is out of a book we developed for people with diabetes. And we are trying to teach portion size here. And there's no measurement. There's no measurement at all. It's all read the pictures. And then you can remember these pictures to remember what size portion. So you need to look at the materials that you're using. Never give patients materials that you haven't read and gone over with them. Is the title compelling? This is a book we developed on weight loss. It doesn't say obesity. It doesn't say weight loss. It says make it happen. Helpful ways to lose weight. An everyday guide for you and your family. Is the layout user-friendly? Do illustrations help tell the story? Well, the cover says this is about eating. They're drinking water, which Pennington promotes. Is the key message clear and easy to pick out? Is the information actionable? Tell you what to do? Is it too much information? Is it culturally and language appropriate? All the materials we've developed, have developed in English and Spanish. This came out of University of North Carolina. It's for congestive heart failure. I like this. It's simple. It's to the point. They are talking about 3 things that people can monitor themselves on and know if they're in the green zone, the caution zone, or the red zone. And so, for instance, swelling. The first picture, your leg, your knee, you know swelling, you're good to go. But by the red, it not only shows you what it looks like, but gives you the number of the clinic to call. So this is very action-oriented. It uses picture. It uses color to convey the message. It's specific and to the point. It doesn't go on and on about heart failure. These are the books we developed, the little self-management guides for the American College of Physicians on weight loss, diabetes, heart disease, COPD, and arthritis. And they're focused on the patient and not the disease. And that's one of the main differences in a lot of health materials. They're focused on the need to know and do. There's a you can do it chapter at the end of each section. And we've done a lot of research studies on these, and they have increased knowledge and confidence in managing disease. They help patients solve self-care problems. A1C was better, BMI was better, and the American College of Physicians has distributed over 5 million of these nationally. Now, Mike had wanted to know a little bit about test. Everybody who's doing research wants to use validated instruments. Look at your validated instrument. It may have been validated on college students. Is it easy to understand? Is it easy to navigate? Patients often struggle to independently read and answer validated, commonly used surveys. In research that we have done, we usually use a structured interview where we just ask patients the question on the survey and get them to answer it and answer it for them, because so many people have trouble. Patients may not understand the stems, just check off answers. If it's Likert scales, don't use more than 5. It's very confusing when the stems are different. One goes to intensity, one goes to quality. The number of choices on the Likert may vary, and all of that's adds to confusion. And avoid yes, no, or true, false. That doesn't give you very much. I mean, you can ask, do you know what a mammogram is? And then you can say, tell me in your own words. And if you're doing the survey, you can have a multiple choice, and you can check off their answer, what category it goes in. So I'm going to teach you a little bit about how you assess literacy, but years of schooling is not a good measure of literacy. Reading comprehension is often 2 to 5 grade levels below the education level. One of the hard things about public school here, we've got a lot of kids in middle and high school that might be reading on a 3rd grade level, and you're just never gonna pass if that's the way it is. You got to learn to read by 3rd grade, and then you read to learn after that. Formal assessments provide a proxy measure of health literacy and can be used to compare results to the literature. And a patient score on a literacy test is an indicator that you might struggle to understand and act on oral or written health information. We can teach anybody anything. We just need to slow down, do one-on-one, do a lot of repetition. All existing tests of health literacy are really literacy tests using healthcare words or context. So let's look and see what they are. I developed the REALM, the Rapid Estimate of Adult Literacy in Medicine. It has 66 words. It's the first one on the left-hand side. There's a short form with 7. There's a form for teenagers, Realm Teen, and a short form for teenagers. The TOEFL is a comprehension test. It uses a closed procedure where you fill in the word that's missing from a multiple choice list, and it uses common health materials like preparation for a test or Medicaid instructions. The newest vital sign is an ice cream label that you have to interpret and are asked questions that assess a little bit of math and interpretation. And then Lisa Chu developed qualitative assessment. How confident are you in filling out medical forms by yourself? She started out with 20, got down to 10, and then got down to 3. And then recent studies have found that this one will do. It's correlated with the Realm, TOEFL, and newest vital sign, but it's not as sensitive, or it's not as specific a test. So since it's self-report, people will say they're very confident when maybe they're not. Also, it's kind of a vague question, and it depends on what the medical form is. The newest vital sign and the TOEFL are available in Spanish. the realm is not, because English is a very hard language, and French or Spanish, just because you can say I took high school Spanish, I could fake my way through saying a list of words. That doesn't mean I could comprehend what I'm reading or be able to use it to really communicate with somebody. So here's some caution. I don't suggest you use these tests for clinical use unless you're going to assess in the aggregate the whole clinic. Because if a doctor finds out, or a researcher finds out, somebody's reading on a 5th grade level, what are you going to do differently? Now, it's a great variable to have in doing research. You could find, for instance, that people with low literacy have more trouble adhering to instructions or adhering to the protocol or whatever, attending appointments, whatever you're looking at. So it's good and easy to add in research, but clinically, I'm very hesitant to put it in the medical record. And testing a patient, given the realm, doesn't confirm they can understand and act on health information. And there's no evidence that literacy testing improves healthcare or outcomes. The thing that does is using plain language and teach back. So tell me how you're going to do this. Show me how you're going to do this. Also, universal precautions. We should assume that everybody is going to struggle to understand what we tell them. And so we need to use plain language and teach back, and we need to have user-friendly materials. And increasingly, that's hard. Like with adolescents, you know, they probably wouldn't respond to a handout, but they might to a text or a YouTube. So how do you reach the audience that you want to reach? Now let's talk about research a little bit. Clear oral and written communication is essential in research, and research is changing, and it is a slow process. We need to slow down and truly have discussions with people to make sure they're truly informed, and if they're informed, they may decide they don't want to be in the research project, and that's fine. It's completely voluntary. And today there's more data sharing. A lot of studies want to use biospecimens. Where are they going to end up? The main concern people have often about research is, what do you want me to do? Is it going to cost me anything? How many times do I have to show up? Where do I have to go? But beyond all of that is privacy and confidentiality. Who's going to have access to this information? If you're Hispanic, you may wonder, is this going to deport you? You may wonder if this is going to get you kicked off your insurance, your employer, etc. And there's growing regulatory scrutiny, and funding agencies are concerned that patients are not understanding, but IRBs and other regulatory agencies have a lot of hoops that we need to go through. So here's a checklist. Is it written in plain language? Are terms consistent throughout the form? Is it written in active, not passive voice? Your signature versus signature of the patient. Is it formatted for reading ease? Use bullets and white space and headers. Is it too long? Most consent's too long. Is the information manageable or overwhelming? What is the plan for discussing the information with patients to allow enough time for the research assistant or CRA to be totally informed about the study, to answer any questions and let the patient go home and think about it if necessary? Does the form and consent discussion help patients make a decision to participate? And then you got to figure out if the IRB is going to approve it, which you've got to have. So here's some tips. Simplify and shorten complex language. So this sentence is over 50 words. Nobody can handle a 50-word sentence. You've been selected as a possible participant in this study because you have moderate to very high risk of pulmonary embolism. It's not known if retrievable vena cava filters will reduce mortality, blah, 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 blah. Are you still listening? So here is an easier, shorter sentence. You're being asked to be in the study because you have a pulmonary embolism. It's a clot that goes from your legs to your lungs. To the point, specific. Anytime Connie and I are asked to simplify things, we take little chunks and we bullet them and we begin to take out words that are not essential, and there are always a ton of them. So, can you make this more to the point? The goal of the tissue bank or repository is to support the LSU HSC Department of Surgery research in order to improve our understanding of those molecular factors, blah, blah, blah. So, that's not very patient-centered. That's all about the tissue bank and the Department of Surgery. The goal of this research is to learn what makes cells turn into cancer. So here's some reading ease tips. Use active, not passive voice. Break text into manageable chunks. Lump and chunk it. One idea per paragraph. Limit the paragraph to 3 to 4 lines. Aim for less than 8th grade level. But the reading level is just the tip of the iceberg. And to have a lower reading level, you have to have shorter sentences and shorter words. The average education level of adults in the U.S. is 12th grade or higher, but the average reading level is about 8th grade. And their comprehension level may be about 5th or 6th grade. So here, this slide is clumping this information. This is a research study. You're being asked to take part because you have COPD. There are not many ways to treat COPD, blah, 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 but you can bullet these and use some white space that gives you breathing room. So this is written on about a 6th grade level, and it's more manageable than a lot of things. So here's another long paragraph, and it's got too many ideas in it and too many words. And here's the same information in a 4-line paragraph. So it's not rocket science. Any of us can do this. I will tell you from experience, it's more time consuming than you think. And Connie and I already do it as an iterative back and forth process. It's always good to bring in patients to see if they can understand it and what word they will use for certain things. We're working on materials for cancer survivors now, and they didn't like the word cancer used over and over. They didn't like the term survivorship. We had examples of foods that are not good for them to eat. They said, well, you need to tell us what we do need to eat, not just what we can't eat. So this is another example of using bullets and lists and less text. Probably it would be better if the page on the right were 2 pages with a little more breathing room, but the page on the left, I don't think anybody tuning in today would wade through all of that. So the more you can break it up with bullets and white space and headers, the better. So that's just what I've been saying. Use white space, bullets, simple headers, short sentences, lump and clump, limit paragraphs 3 to 4 lines. And this was a federally funded study on consent, and these consent forms were made with patients, and they were great. But the problem is most our RBs will not accept this. But this is the essence of what informed consent is. That it's to help patients understand what you're asking them to do.
Terry, there are a couple questions that pertain to what you just covered.
Okay.
How do you feel about reading level tools like those found in Microsoft Word that define the reading level of a document?
Oh, I think they're great to use as a start. I mean, so one of the ways you can figure out, I mean, you can run something by the Flesh Kincaid, which is the easiest to use. And, you know, if it's written on a 12th grade level, a 10th grade, even an 8th grade level, you can see if you can simplify it. I think that's a good first start. But reading level is the tip of the iceberg, but that's a first step for me is what's the reading level now, just kind of out of curiosity, because I always like to challenge myself to get it down and to make the format easier to read.
And then great, thank you. And then the next question was about, you know, what you alluded to, that the IRB does demand full details and specific language. Do you have any tips for IRBs?
Yeah, and CaTS IRB is very interested. All of them are, and we've worked with them, and we developed a booklet to help you simplify. That we developed with every CaTS IRB was involved in helping make this little booklet about making informed consent simpler. There's certain words that IRBs want you to use, and you've got to use them. And like if you're developing something for a funder, if they want certain wording, then, you know, they're paying you to do this. But I think IRBs, CaTS IRBs, I know, really want to communicate the message. The problem is legally, sometimes they think all of this information needs to be in there. And that's why these summaries, these patient summaries, are really good. I gave a talk at St. Jude's, and the consent process there is remarkable. They meet with a layperson and go over the consent. Then before they ever go in and talk to the doctor, the parent goes back to the room with the materials and with the lay summary. So there's plenty of time to mull over this. But of course, by the time you get to St. Jude's and your child has cancer, you probably want them to do anything they can to save the child's life. But the informed consent there is so important, because the cancer treatment, whether it's radiation or chemo or surgery, may have consequences when the child is an adolescent, even though the life is saved, or an adult. So, you know, it's a dance with the IRBs. It's always good to be friends with the IRB and ask them for help. Any other questions?
Thank you, Terry. Yes, the question is, how about brief summary in addition to full, long IRB required ICF?
Oh, I'm all over it. You know, people like the Cliff Notes in high school. So, you know, what is the brief, plain language summary? And talking to somebody who is very knowledgeable about that study is very helpful. Any other questions?
No, that's all for now. Thank you.
Okay. So risk communication is important, and it's important to provide both positive and negative frames. And a lot of consent has risk communication in it. So 6 in 10 men who have surgery to treat prostate cancer will be impotent. This means 4 in 10 will not. Also, it is really important to give absolute estimates and not relative. Drug X could reduce your risk of breast cancer by 50%. Oh man, I want drug X. It's $10,000 a month. I don't care. I'm going to figure it out. Well, drug X could reduce your 5-year risk from 4% to 2%. So that's a different calculus in your head. But remember, people are not too good with percentages. So the more concrete and specific, the better. Would reduce your risk from 4 in 100 to 2 in 100 patients. When benefit was expressed in relative terms, 57% of patients chose to take the drug, but in absolute terms, only 15% chose to take it, and then 16% were indifferent. So how we present things can be important. Changes appear larger using relative versus absolute. It can be inappropriate to lead patients to believe the treatment is more effective than it is, and they tend to think If there's in a randomized controlled trial that their doctor wouldn't recommend it unless they were going to get the miracle drug. Sometimes they don't completely understand that they get standard of care and then standard of care plus something that we're trying to test out that we truly don't know, and it is random. But physicians are more outside the research. Physicians are more likely to recommend treatment if the information was presented to them using relative risk. And so a lot of times they get what the drug representatives tell them. The other thing to remember is that tables require a certain literacy level to navigate and understand. And you learned how to use tables in school, and if you didn't do well in school, or you didn't finish, you dropped out of high school, you may never really have learned to understand, to navigate and understand a table. And so it's important to use tables with caution. People with higher literacy skills like graphs and tables because they can easily get the information. Others, the table is confusing. What do the headers mean? So just be careful using tables. Make them as easy, to the point, help the patient navigate them. So here's some recommendations. Don't make any assumptions about patient understanding. Make the implicit explicit. The more concrete and specific we are, the more likely the person that we're talking to can understand. Ask for open-ended questions to assess for understanding. Tailor information for the patient. What's their understanding of the risk of the disease, the treatment? Can they get out of this study if they want to? What are the risks of being in the study? Reinforce the important messages. Confirm their comprehension. And simplify numerical concepts and percentages and probability. Here's some steps to improve the process. Prepare and allow sufficient time. Arrange quiet, private, non-cluttered space. Let patient include family member if they want to. Use document to point out key messages. Use that summary. Walk the patient through the form. Engage the patient. They're a crucial partner. Verify and document comprehension. Teach back is really important for consent. So tell me in your own words while we're doing this study what you're going to be asked to do. Is this going to benefit you in any way? Are you going to be compensated? What's your understanding of the risk? Can you decide if you want to get out of the study? One of the things that I've learned from CRAs is they sometimes say, I go through this many times a day with a patient. Sometimes I forget what I've said. So I need to just make sure that I have communicated clearly to you. So the recommendations for health literacy for consent and for all materials and oral communication. All materials need to be written in plain language and formatted for reading ease, and that includes what's on the web. Our health information and websites need to be understandable, actionable, and developed with input from patients. Pictures and color can help convey key messages. Remember the UNC heart failure study. Messages need to focus on the patient and their need to know and do and benefit, as opposed to the focus on the disease or the health system. We're working with the Medicaid office now, and sometimes those forms are so bureaucratic, focused on the Department of Health rather than the patient. Ongoing touch points are always helpful. One of the things in some research studies we're doing is, I don't know, like on the Propel study out of Pennington recently, using health coaches to help patients lose weight. I didn't know the dose of the touch points. At first they saw a health coach weekly, and then they got calls weekly, and then it was supposed to move to monthly. But how many people need, and what I've learned is that varies on the problem and the person. but those ongoing touch points are needed to help patients improve their behavior and outcome. And the only way to confirm that patients have understood us is to use teachback. And I use teachback all the time, not only with patients, but I'll say, well, this is what I heard you say to me, so I'll teach it back to them. I hope that you will implement some of these messages into your work with patients and the public and the communication that you're doing. But I'll be happy to answer any questions you have.
Thank you, Terry. I see a message is coming in now on the chat window.
Can you read it to me?
Yeah, they're still typing. Let's see.
You know, I see David Dugart. If you're the David that's up here, that's the librarian. The librarians often are good health communicators. People go to public libraries and medical libraries and ask for help in getting information. And often the librarian can be a big help, not only to the researcher, but to the public.
That's great. Terry, they're still typing. Oh, here we go. Can you comment on designing applications, technology for health literacy? Also, how to assess technology with health literacy?
Well, that's interesting that the next National Academy of Medicine Roundtable, which is going to be in May, is going to be on that. That's a huge field. That's a great research project. I mean, everything's going electronic, and the communication and the ethics haven't caught up yet. And so how do you communicate it to the audience you want to communicate it to, and what is the best way, and can they navigate it? Can they navigate the links and get to the website? The federal government thinks if they just put everything online, it's accessible then if you know how to access it, but is it understandable? And there are I don't know how many apps there are for health. There are a jillion of them, but some of them have proved very helpful. A lot of times people quit using them, but it's like, I still think we're in a huge learning curve there. And I challenge medical students to develop. They're clever, they're more electronically engaged than I am, and I think it's just a whole new world about how we're going to communicate with patients. I mean, people are using cartoons and all kinds of things to try to do consent now, and so we're still testing all of that.
Wow, that's very interesting. That's a good question. Good. Well, Terry, I don't see any other questions coming through. Usually when I say that, one pops up. But I don't. Oh, yeah, exactly. Just on cue. Here comes another one coming in. So while we wait. Jill writes, "Hey, Terry, it's Jill, your old RA."
Oh, Jill! I want to tell you something. I was at a conference and I play a video that Jill made. Jill, I guess I'm outing you. Jill was diagnosed when she was 14 with type 1 diabetes, and there's so much she has to do to take care of herself, and she's so on top of it, and she's so athletic and engaged in everything. And I just think that doctors have a hard time knowing all that it takes to manage diabetes and how much patients need to partner with a doctor and get some support for managing their conditions. But I just think there was a young woman, Jill, at this conference who heads a group of people with diseases you can't see, and all the issues they go through as adolescents and transitioning into adult care, about even dorm room and getting into college and diets and all kinds of stuff. So Thanks for making that video. I see you once a month when I teach the medical students.
That's great. She
you ought to get Jill to. I have some great videos that any of y'all can see. A lot of times they tell the story because you get the person with the situation there and you want the best for them.
Well, she gave me some smiley face emojis and said she's working on a study now where they do stuff on iPads, and that's definitely a challenge for some of the participants just to do a survey on there. So definitely appreciates it. That's great. Great.
Well, any of y'all, David Alexander, do people fill out any kind of evaluation to be happy to know what would have been more helpful or what you're going to do with this information?
We do have one. Actually, I don't have it ready in the slide deck, but we have a REDCap survey that we utilize for this.
But then they have to go to REDCap, so you need to make it easy for these people to tell you.
You're right. You're right. Yeah, I should have a click right here so that they can go.
Right. Click here and do this in the next 2 seconds. Otherwise, it's probably not going to happen.
You're right. You're right. I don't, and I even when I was doing the REDCap sessions, I'd get very little feedback. So you're right on. That's exactly how we should do it. I have another question that came in from Tanisha. She writes, how do researchers ensure that content is culturally competent within health literacy relative to different geographic locations, ethnicities, cultures, customs, etc. of target populations?
Well, the best materials, Tanisha, is when you work with a certain group, like in rural areas or Hispanics. Of course, Hispanics are different. There's no one African American or one Hispanic. But if you're working with people, is to partner with them and get. I really believe that we cannot develop materials unless we get the people, the users of the materials, to help us. What is it that you need to know? How do we say this in a way that lands right on you and is understandable for you? So we have to partner with people that we want to use the materials.
Fantastic.
I'm at this meeting on adolescence. It was amazing. They started showing adolescents who had chronic diseases all these things, and they got their input on even doctor visits, because there was so much they didn't like about how the doctor visits were set up. A lot of the words that were used, they said, oh man, this is terrible. And they started reframing things and teaching the providers how they wanted the appointments set up and how they wanted to get information. So we need to work with the people that we are aiming the materials to.
Fantastic. Great, great. Well, Terry, I want to thank you so much for today for closing out our webinar series for 2019. We don't have another one planned for December. We may have a surprise presentation, but there'll be more details about that. If you have more questions for Terry that you think about on the way home, you can always send those to info@lacats.org, info@lacats.org, and we'll get them to Terry. And I've jotted down the participants today. I'll try to get that feedback survey to you as well, because that's very valuable. So, Terry, anything you want to say in closing, or can we wrap up?
No. Go forth and do good work.
Great. Always a pleasure working with you, Terry. Enjoyed it, and always very informative. Thank you so much.
Okay. Bye, guys.
Bye, everyone. Thank you.